I'm pleased to introduce now our next speaker, Diana Hekerem. And I guess many people here will have known Diana in her, a series of previous roles where she was, how shall I say, dotting around the country and heavily involved in formulating and developing services to meet the needs that people have towards the end of life as an employee of Marie Curie. And I was very pleased to hear when she was moving job that she was going to a position which she now holds as Head of Strategic Commissioning Support at the iHub, which is part of his. And I think for us as a community with an interest in care for people towards the end of life, it's good to know that we have somebody in such an important position in the new world of integration who has such a long-standing background and understanding of some of what we're trying to deliver for people towards the end of life. And Diana's, when the music stops playing, she's going to open a window on the whole mysterious world of strategic commissioning.
Right, hello. I think coming from Healthcare Improvement Scotland, we should talk about standards, setting standards. So the standard for the next 45 minutes I've set myself is I am going to inspire and energise you, and I suppose all things can be measured, even what matters. At the end of it, I'll find out from your evaluation forms if I achieved that or not. So all good things can be measured, and you would expect me to say that. So I have the joy of trying to tell you about strategic commissioning and why it's so exciting. So firstly, strategic commissioning is not about buying cheaper pencils. It's not about driving down a tendering process to thrash the last penny out of the voluntary sector. There's lots of misunderstanding when people talk about commissioning, when they actually mean procurement, or they mean a commissioning model that's mainly on the news. We know how much now we're informed by the Daily Mail and our views of what health and social care should be. So strategic commissioning in England is not the same as commissioning in Scotland and has been set apart really differently. The guidance on strategic commissioning talks about that it should be inclusive, spanning health and social care and co-produced. We have a real opportunity. I have over the last year met a variety of people from public health, social care settings, independent sector, social enterprises, acute consultants, care workers, who all are passionate about the same thing, that we need a welfare system for the next 100 years that is radically different than today. That makes our communities more empowered in what they do, that engages the service users much more a voice about what they're doing, that recognising that the role of the welfare state, as it were, is to support people to have their human rights being met, and that it's not about treating sickness, it's about supporting wellness in our society. And that is why, for me, I'm so passionate about the work I do, because fundamentally, all the good stuff is in the dull stuff. Strategic commissioning is what decides how that money gets, how those assets get deployed, how we go through that process of redesigning our health and social care system for the next 100 years to the one that we want to grow old in. So there is guidance imminently, an advice note as part of the commitment in the Strategic Framework for Action. We know an advice note about strategic commissioning for palliative care. So why do we need one? Why does everything I've not just said apply to palliative care? But there are some challenges for palliative care. The great work that Anne Finicum and the team at the Research Forum did along with Marie Curie on looking at the research evidence into needs. If strategic commissioning is about understanding the needs of our population, how we meet it, what sets it apart is this uncertainty. The evidence really pointed in those trajectories of dying now, where people have all the multimorbidities, it will be uncertain. We can't plan it. People who've worked with me over the last 10 years know that one of my greatest frustrations is a meeting I've never yet had with the Grim Reaper, where I've asked him if he could sort it out Monday to Friday, 9 to 5, one after the other. That would be much better in health planning, but he's refused to come. The other challenge is the voice of the lived experience. It's really big in health planning right now. We understand that we really need to get the voice of the lived experience, and I think our last presentation adequately highlighted that's quite challenging when they're dead. So how do we engage that user experience towards the end of life and after in understanding what services should look like, and where we know from the LSE report on inequities in palliative care that those people who live alone are likely to be more marginalised in their access to palliative care. So we don't even have the proxy carer as the voice of the lived experience. So are we further marginalising those who live alone by never being able to get their points of view? We understand, and it was really highlighted in Jeremy's talk earlier, about the value of education and that tele-mentoring role, that education in palliative care and what the specialists can do to support the wider community needs to be factored into commissioning planning. If we want projects like that to continue, we have to get that that's part of what we need to commission as part of our commission to the hospices or our commission to other specialist palliative care units. The family matter, we know that, and there's a massive range of community assets out there that we can draw on, that want to be part of. And if we regard that community of practice wider than the clinicians, and we understand that community of practice as with the work that Jeremy describes involves care homes and society, but actually involves our churches, our mosques, it involves our people down the local shop, it involves our running groups and our park runs. They're all part of that community of practice potentially if we engage with them and understand that within our commissioning of our assets. And lastly, it is a sector, Audit Scotland recognised it years ago, it's a sector where the voluntary sector and the money that comes into Scotland, the willingness of our society to tax themselves to provide high quality palliative care, to provide good care and support for the dying, because let's face it, that's what all these fundraising running is. It's a way of our societies saying, yes, we are prepared to tax ourselves more so we live in a society where dying is well managed and the people that we love are supported at the end of life. And I think we should be really proud of that. So, after my introduction, I am going to shamelessly try and get some questions out of you, which I've designed. Some of them are about helping us really understand and kind of get a temperature test from you about where we are with some things about strategic commissioning and understanding. And some of it is some questions that I think I know that I face challenges and barriers against, and I'd be really interested in the views of this room and being able to give some feedback that's not just my opinion, because people don't always listen to me, unfortunately. I don't know why. So, to warm you up, strategic commissioning. Which one of these 5? Okay, not that I'm competitive, but you got to about 159? Oh. There we go. Excellent. I was really worried. Sorry, the 12% of you. I'm really sorry. I promise I will do my best in the next half an hour to change your mind. It's okay. If you think about it, every time I walk into a room, I'll pick up the phone, I go, hi, I'm head of strategic commissioning. I see faces full, so I get it. But it genuinely is the coolest thing ever, trust me. So, and just to counter-prove my point, here are the new language. In every sector there's jargon, lots and lots of jargon. In strategic commissioning, no different. How many of these do you think you are familiar with or could define? I'm not going to ask any questions afterwards. I'll not put anybody on the spot. Okay, now this should work. There we go. 1 to 3. Wow, a lot of new jargon out there. Now, given that the billions of pounds invested in health and social care and palliative care is fully integrated, all those 10 terms have a role to play in your jobs. Fundamentally, they're probably what's deciding that you still have salaries. Fundamentally in there somewhere. So I think, you know, like all new ways of working, the fact that it's so wrapped up in dull jargon really doesn't help. So I will try and unpick a few of them and explain why they're not the dullest things since sliced bread. So, and this again is not going to help my cause. Lots of words here. So, market facilitation. What that is, essentially, is a plan that in law, in legislation, each health and social care partnership has to have one of these. and it will define how they spend their money on services provided in the community. That includes hospices, that includes our care homes, that includes our home care providers. But that might also include our sports clubs, our walking groups, our older people's centres, the kind of places and support where actually, if we think about our bereavement support groups and where you would actually like to sign people, be able to sign people to get support, if you think about advanced care planning, the kind of things you would like to have in an advanced care plan, they should be defined in a market facilitation plan. And how you get to that and how you decide how many. So how many hospice beds should I have? How many clinical nurse specialists should we have in our community? How many groups should we have? That's all in your market facilitation plan. So it's kind of quite and actually the ability to influence that and for organisations to think differently about who's in it is really important. Co-production is a kind of thing that's been deemed a bit of a niche voluntary sector thing, but actually shared decision making and planning is essentially what it means. And public social partnerships are the way we stop driving the quality out of our voluntary sector contributions to health and social care organisations. It's stopping making decisions in isolation, putting prices, setting prices low, driving our home care workers out, making sure that their time and tasks and GPS tracked so they can't deliver quality of care to the people in their last months of life. Public social partnerships are about having a different relationship with our community sector, about saying we want to have an empowered, we want people to be supported, these are our population's needs. Who would like to come together to design and innovate solutions about how we better meet those needs? So, who thinks co-production in Scotland is a good idea? You're waiting for your lunchtime coffee. Is that? Okay, we'll see how we go with that. So yeah, 55% if you think it's the bottom, and those 55% are right. The public, 96% of a survey in Scotland, 96% of people think they should be involved in decision making about how local services are run and planned. 81% of people think they should be involved in decisions about how the money is spent. And 86% of people think they should be able to contribute to the delivery of health and social care. That's massive. I hear things where people say to me, in terms of planning and using the voice of the lived experience, people just want to get services, they don't really care about how they're run. Not true. Not true. So here's the question, see if you remembered why I told you market facilitation was really exciting. Oh, I think there's a wee man at the back trying to help me. There we go. Excellent. So we did, I'm glad none of you went for my driving test question. Should you pull out in front of the nearest lorry? No. So I think what we can do as a community of professionals and advocates for good palliative care is to try and make sure that within our health and social care partnerships, the opportunity for that conversation between using that shared understanding is taken forward, and start to have some of those conversations about what you're doing about your market facilitation plan. What's your strategy for getting more people involved in palliative care in our community, and where is that documented? Because it's documented in here. And that's just, because you'll get the slides afterwards, that's just the way it's done technically, with a bit more dull jargon for those who like it. But essentially, it's about understanding, getting out and reaching people who want to be involved, who currently are. So this is still a bit of I always talk about the SDBC conference, there's a bit of there's 60% of people I probably know and have worked with in this room. We need to go out and engage with that community of practice much, much more. And that's where market intervention is the strategy for doing that. And how we structure that, how we decide how the money is spent and paid for, what goes in our commissioning frameworks. So is it a time and task commissioning framework, or is it not? Which takes me to my last thing. So public social partnership is a type of procurement, and I'm sorry, I'm now aware I'm losing you. But what it means is, instead of saying, I've decided the answer, here is the price. This is the mechanism, and it's happening in Scotland. They changed the Procurement Act in Scotland a few years ago that says you do not have to just put out to tender solutions. You don't have to say, this is the service I want, who will tender for it. You can say, this is the problem that I have, who wants to help me be part of finding an answer. The legislation enables that practice. Because people think procurement's dull, nobody knows that. And so the take-up of it is really low. But actually the opportunity for us all in our practices of work to be differently engaged in how this happens. So here's some examples. These are all, there isn't a right and wrong here. This is just to kind of get a sense check what you would do. But these are all opportunities that you could use a public social partnership approach to do. If you could challenge your IJB to do one, what would you challenge them to do first? Okay, so the improved use of non-physical support for community palliative care is the favourite, with improved use of advanced care planning across all settings of care. That's really interesting, but actually shows you where the opportunities are. So this will be really useful for within planning, for us to think about what can we do nationally to try and create an environment, and across the IJBs in Scotland, to think about how they might use this mechanism and bring case studies forward, which we can do through Mark, about the kind of way that might work for you and support some of that. So, numbers, measuring stuff. So unfortunately, we know the government likes to measure stuff. So the Daily Mail likes the government to measure stuff so they can tell them how badly they're doing. So they need to measure stuff about palliative care. I've sat in a lot of discussions over the last few months about what they might measure. There is an awareness that it's complex, there's an awareness that it's challenging, there's an awareness that there isn't one measure that will give you the totality of the answer, that you need a narrative. But they still want a measure. You're not going to get them away from it. So if you were to choose, if I was to speak on your behalf at an event in the future and say, do you know what, this is what the palliative care community think is the most important thing you could measure, one thing that would help them know that the palliative care and integration was working for them, what would it be? Okay. Now, I'm not a betting woman, but I'm guessing it's going to be 5. But No? Excellent, okay. A Voices of the Bereaved survey, okay. And days spent, so the one, yes, the one that's currently in the 6 measures at the user-end integration is the days spent in the community in the last 6 months of life. So there's good support there for that to be continued, but also to understand what a kind of Voices of the Bereaved type survey might tell us as a way to understand that experience. Thank you. Was that what people were expecting?
No, I think it's number 4.
Oh, 4, have I got it wrong? Oh, ACP. So I'm trying to look at it upside down. Okay, so the numbers, the percentage of the population with ACPs. Now, one of the challenges I've had around that as a measure is it doesn't measure quality and it doesn't measure outcome. You could have lots of really rubbish ACPs which families aren't involved in. But do you think in general that as a kind of finger in the air that things are working, it's a good enough measure? Okay. Thank you for helping me look upside down. Okay, so this is the challenge that your IJBs face. If you had a bit more money, if they managed to eke out a chunk of money out of the system, or there was a development pot of money made available, so you could do something significant with it, but you can only spend it on one thing, what would you spend it on? We will get there. Wow, quite a strong view for nursing and healthcare support in the community. Now, I did wonder, and what I might be able to do at the end is get the database from behind this and see if I can match it up to what everybody said their professions were. So I won't individualise you, but how different people's professions might have influenced that answer would be quite interesting. But a really strong support for more health and for more nursing and healthcare support in the community. Okay, so I just want to understand how your roles are now as people working in the field, either in delivery or in support of that delivery of care. How many settings do you think your role covers now? From a person's own home, care homes, community NHS, acute NHS beds, or kind of an outpatient day facility type of setting? How many places do you think your role has an impact on, kind of directly impacting on? I didn't put an option 6, none of them, did I? Okay.
Was there a common or same of these? Because there was no sort of facility to vote for a hospice, which isn't acute, it isn't NHS, etc.
You're very right.
Sorry.
And I of all people should know better. Hey-ho. Sorry. So we'll assume that the rest of them, the other, covered. But in general, there's a good spread. I think that's what we can say, is that there is a good spread of provision. I think hospices are part of that community NHS inpatient. But yeah, you're right. I used to have a flag in my old job where I used to say, don't forget about the hospices. I must have put that one away. It's definitely in the devolved nations, and don't forget about the hospices. Okay, so one of the new exciting tensions that we have in health and social care is the tension between regional planning and locality planning. So the integration joint boards our partnerships are all being directed and guided to increase the amount of locality-based planning that goes into their strategic planning and their strategic commissioning decisions around services. But we all know, and I think our presentations today have very carefully alluded to, how challenging and how much time the acute sector still plays within a person's journey of care in their last years of life. You know, that there isn't this, you live at home and you die well in the community and you never see a hospital. That is a sort of almost modern fallacy or expectation. So the regional planning and what that will do in supporting people is happening slightly separately to the locality planning. But for the populations that you serve, they are both important, and I'm wondering how much people have been involved in those. Okay. So that's quite interesting. That both of these planning processes are deciding how palliative care happens and what support is available to our patients. All the presentations this morning talked about a need for things to be different. They talked about more carer support required for our patients. They talked about the need for a community of practice. They talked about a need for greater education and support. They talked about engaging with the care home sectors in supporting better palliative care practice. And those decisions are happening in those processes. And so I know I'm standing here as the dull person between fascinating speakers who have really cool things to say and make us want to cry and gasp and hold our chest. And I'm talking to you about market facilitation plans. But this is how the money gets spent, and this is defining the services and how all the things that you want for your patients and the people you support, this is where they get decided. So I would really encourage some involvement in understanding what's happening and participating in that. And even more interestingly, you're all citizens of Scotland. And the legislation and the drive is that our citizens should be involved in our regional planning and our locality planning. And if people who are passionate enough to spend a day here understanding, and we're not being involved even in our own areas, locality planning. So, person-centered care. How do we get person-centered care into our practice? So, here's 8 lovely statements for you to read. And then how many of them do you think apply to your work? You might have to do a little bit of lateral thinking, depending on what your job role is. All right, I think we're there. Okay, all 8 of them, fantastic for the majority of people, but very much up the higher end. So these are all good statements of practice. At least half of them apply to your work, which is fantastic because they're from 2 very current documents. Now, here's the challenge for you. How many of them are from realistic medicine? Just answer quickly. Honestly, I'm not going to check anybody. Your attendance points aren't dependent on you getting the right answer. Anybody from Marie Curie was there on Wednesday doesn't get the answers right is in trouble, though. Not looking at Richard. Okay, we'll go with that. 8, fantastic, isn't that exciting? And the majority of people in this room think 8 of them are from realistic medicine. The actual answer, I'll tell you the actual answer in a minute. I'll give you the next question. How many of you are from the Self-Directed Support Implementation Plan? Okay, a lot more don't knows, I feel. Okay, so half. I think all of them are from the self. Do you think I'm that mean? Okay, so the actual answers are 3 of them are from realistic medicine, and 5 of them are from the Self-Directed Support Implementation Plan. Has anybody read the Self-Directed Support Implementation Plan? Anybody thought it had anything to do with their jobs at all? So actually, and as I was saying to your later speaker earlier today, in my job role, I've now had the fantastic opportunity to meet people from right across different bits of life, digital, social care, people within COSLA, right across. There is a real groundswell of direction and desire for this kind of society to be our health and social care society, and for this to be, for when we're old or not so old and dying, that this is how we want to be treated, and this is what we want for our friends and family. And we're still doing it in silos, we're still doing it in bubbles, that your biggest advocates for getting the decision-making, those early conversations, potentially are the social workers working in the practice, who are already beginning to engage with people about shared decision-making, about risk-enabling practice, about those good conversations, about the fact that you might die, you can't get everything that you want. There are difficult choices to be made, but choice and control is what matters. It's not getting everything that you want, but being empowered, I think as Nizia was saying earlier. It's about having those discussions and getting into that conversation. Jeremy, you were talking about it in your presentation, about healing. This is about Self-Directed Support Implementation Plan. That's about healing. That's about healing. And if we want to maximise this kind of society, we need to start looking out silos and finding our allies. So that, like kids in a swimming pool, if you get them all to move, to take a step, the water doesn't really move. If you get them all to run in a circle, anybody ever done that with your kids? Got like 30 kids to all run in a circle in a swimming pool, huge tidal wave, and the kids end up can't put their feet on the ground anymore. We can do that if we recognise actually, there are people right across our health and social care system who are wanting to have good conversations that empower people. So my last question, and then it's lunch. So do you think, so I've sat in palliative care conferences for the last 10 years and had different conversations about digital and technology. Where do you think we sit with it? So that's really helpful, that about half of the room think there is a role for more digital and technology as part of care. And what is, am I done? Is that? Wow, that's, you normally get a subtle wee red card mark. I don't know, just turn the lights, get off the stage, there's lunch. Right. Somebody in the back is going, she's so dull. Right. I know the answer to the first question now, okay. So, the thing is about, I was going to say, that quote at the beginning about strategic commissioning being the new rock and roll was from the new digital chief officer in the Scottish Government, who wants to see service user-led, psychologically informed services with digital at the front. So stop digitising the way we exist now in the paternalistic way we deliver services. Let's ask people how they want digital involved in their life. We've had good examples throughout the day about how important it is. but getting service users to say, actually, I could just text you from home if I'm feeling a bit crap today. I'm feeling a bit isolated. I could maybe just reach, I might not be able to get out of my bed, but I could maybe reach out over my phone. And maybe that's what people want, but we need to ask them. So that's been really, really helpful. I hope by the fact that the lights have gone up isn't a sign, and I hope you found it interesting. I don't think we've got time. I don't know if you want questions? Lunch? One question. Mark says I can have one.
You can ask questions.
I thought it was going to get at me. Is there a mic? There's the lady here in the white top.
The lady here in the white top.
Run!
Hello, my name is Penny Halliday and I'm chair of the Dumfries and Galloway Integration Joint Board, and I was very interested in your presentation. I think for me in particular, the report that came out recently from the government regarding integration authorities' ability to co-produce or to use co-production, and that integration authorities have got co-production mentioned in all their plans. They're talking about it, but they're having difficulty moving from talking about it to actually putting it into practice. And there are real difficulties in trying to put co-production into practice, and I'm wondering, you know, what your comments are regarding that in view of the challenges that we have, particularly in health and social care, and trying to give the third and independent sector a voice.
So there's a really nice book by the son of Stephen Covey, who did the 8 Effective Habits of Leaders, called The Speed of Trust. And it recognises that actually it's about building trust. And our challenge with co-production is we've done 2 things to it. We've given it a niche, and we've said it's, you know, we do co-production projects. We don't have it as a way of, as an approach to thinking about health and social care planning. We've also broken that trusting relationship with our voluntary sector in a lot of ways, where a lot of the voluntary sector have had, you know, such penalties put on them. The introduction of the living wage and how that's impacted on the third sector, and not in any particular area, but in some places, you know, where it's actually caused third sector organisations to go out of business and not be able to do that. And I think the biggest challenge is some of the stuff I've been talking about today. It's the jargon. It's the fact that you talk about co-production and nobody in this room thinks it's got anything to do with them. You talk about a market facilitation plan and people are like, oh my God. You talk about the changes to procurement legislation and nobody wants to listen to you. And that is the challenge, that actually if we're going to change things significantly, we actually, if I said to any of you, can you set up a co-production around your future service delivery, you'd be like, that, what's she talking about? Yeah. And that's our challenge. Our challenge is to, and it's also where we've got this real tension between, and I'm trying not to be stared at from the back of the room, you know, we've got delayed discharge figures. Our chief officers are sitting there being hammered by your delayed discharge figures have gone up, your A&E waiting time's gone up. We know that to make transformational change, things will get harder as we go through change in order to have a rapid improvement. So part of what our role and responsibility, and people in roles like yours can help, is about holding that nerve. We have to hold our nerve through change. We have to say, let's do this differently. Let's build that trust. Let's think about time for the relational, to build those relationships, build the trust, build the conversations. And it might mean that we can't fix the delayed discharge figures for the next 3 months. But yes, we could get a cheaper voluntary sector social care provider to get our dying out of hospital like that. But that's not going to make the change that we want. So I think it's a lot about leadership, systems leadership, and holding our nerve as we begin to all engage and begin to all provide the support into that conversation.
Thanks very much, Diana. And we're out of time. I would like to have asked you more questions, I think. But I know that you're not around for lunch very long, are you?
Yeah, about half an hour.
Okay, so you've got half an hour, so you should be able to get in 12 in the way that she's asked you for 12. But thank you for helping us through some of the concepts which are difficult, personally, I find to get my head around, and for unpacking some of the jargon for us so that at least we have a bit of a better understanding of some of the quite radical change that is happening. And I think importantly, the opportunities that may be there to grasp if we can understand where they are. So thank you very much.
Thank you.